Welcome to another episode of the PD Exchange, a podcast focused on peritoneal dialysis and brought to you by the journal Peritoneal Dialysis International from the International Society for Peritoneal Dialysis, ISPD. I am your host, Dr. Nikhil Shah. I am a nephrologist at the University of Alberta, Edmonton, Canada. And with me, as always, is my co-host and editor-in-chief of PDI, Dr. Jeff Perl. He's a nephrologist at the St. Mike's Hospital in Toronto, Canada. For our show today, we are discussing the ISPD recommendations/guidelines for assisted PD, which will be published shortly. For today's episode, we are joined by Professor Thierry Lobbedez from Caen, France, which leads the way for PD utilization in France. He has been involved with PD for more than 2.5 decades and works on assisted PD, integration of PD in patient pathways, and clinical epidemiology. Next, we have the Director of Clinical Education and QI at Ontario Renal Network, Janet Graham. She is an advanced practice nurse in nephrology, Regional Director of Nephrology at the Ottawa Hospital, with more than 3 decades of nephrology experience. She is passionate about improving the life of CKD patients. And we also welcome back Dr. Matthew Oliver. He's a nephrologist and division head at the Sunnybrook Health Sciences Center in Toronto, Canada. He is a former president of the North American chapter of ISPD, and his work focuses on optimizing use of peritoneal dialysis. A warm welcome to all of you, and thanks for joining us today. And handing it over to Jeff now.
Thanks, everybody, for joining, and really looking forward to some interesting discussion. So we're getting some assistance today, and the assistance we're getting is about assisted PD. And so I think that this is a long time coming, that the ISPD has consistently endorsed education and advocacy for trying to grow and promote peritoneal dialysis, of course. And I think one of the cornerstones of what I think the ISPD stands for is to make PD accessible, equitable to all, and improve the utilization for PD in whom it's appropriate. So I think assisted PD is an excellent tool, and I'm looking forward to hearing more about it. Thierry, do you want to tell us a little bit about the guidelines and what prompted the guidelines to be developed, along with Matt, who you co-led the guideline writing with?
Thank you, Jeff. So we were asked by Raj Mehrotra and Edwina Brown about 1 year ago to work on this position paper on the behalf of the ISPD. I have to say that it was also a great opportunity to meet people from abroad, to share opinion and expertise about assisted PD. I think that the main point is that nephrology teams want to offer a free choice to their patient between the different options to treat end-stage renal disease, particularly dialysis. So we all know that there are patients who really want to be treated by PD, even though they cannot do their peritoneal dialysis exchanges by themselves at home. Theoretically, assistance can be provided by relatives, by the family, but in the same time, we all know that the family assistance is declining, particularly in the high-income countries. There is also the burden of the disease for the family that could lead to caregivers burnout. So for us, it was quite obvious that there was a need for a paid assisted peritoneal dialysis. Main objective was to justify assisted peritoneal dialysis, and I think that it was obviously needed. The main objective of the review was to describe the different aspects of assisted PD and to also to provide recommendation to increase the availability of assisted peritoneal dialysis. Thank you.
Thanks, Thierry. And And Matt, maybe to continue what Terry said, I know that there was a lot of discussion, and I'm going to correct myself and say, of course, this is a position paper because, and we'll talk about what evidence we need to generate. At this point, there's, certainly evidence that's been out there, but limited evidence gaps in terms of delivery of assisted PD. But I wanted to ask Matt, there was a real discussion about what the definition of assisted PD should be. What is it and what it isn't? And maybe you can take us through your perception of the definition and as you guys described it in the position statement.
Yeah, thank you for that question, Jeff. I mean, we actually originally used the word definition, but we moved away from that and just talked about limiting the scope for this position statement. We wanted to focus the scope on paid assistance through the healthcare system because that is the main strategy we're trying to facilitate, is getting payers of healthcare, whether it be government or private payers or charities, to expand the use of assisted PD. There is a lot of other assistance going on in the background, particularly with families. And in some areas of the world, things like domestic workers are in the home already, and they're also providing assistance that's been described. But we sort of wanted to draw a line between those two things because we were trying to facilitate sort of the first paid form of assistance. Also, family assistance, for example, is very challenging to measure. It's probably going on in the background in many, many patients. And so, if you included family unpaid assistance as part of assistance, you could argue assistance exists in all parts of the world almost, because families are always helping the patients. So that's kind of why we did that split. And we really wanted to focus on paid assistance. The other thing we wanted to sort of take out of the scope was, say, a PD being provided by staff within residential institutions. So this would be something like a long-term care home where the actual staff employed by the home do the assistance. However, we did include, there are some models where home care nurses are visiting long-term care facilities and providing assistance through that mechanism, and we did include that. So that was kind of gives you a sense of where the scope was limited.
Question about the scope. In some programs, and there's a lot of variability in the way it's delivered, in some programs assisted, and then these are going to be sort of rapid fire questions to you. In some programs, assisted PD is delivered by nurses or other healthcare professionals. Under your umbrella, we're talking about some form of a healthcare professional or somebody trained to be able to do these procedures, correct? It need not be a nurse as in the definition.
Correct. And that is a big distinguishing factor of assisted PD programs. Some programs use registered nurses. Some programs use sort of practical nurses, though they have different terms throughout the world. But we also included non-healthcare professionals that are trained but paid. And we also included family members paid, although that last form of assisted PD, because it's again paid by the healthcare system, is relatively rare. There are a few models in places like California where family members can receive payment to assist with patients. So that is a model which we included, but we could not find really any publications around that model, but we do know it exists on a limited basis.
Interesting. And so we talked about the who of assisted PD. Let's talk about the what of assisted PD. Tell us the scope of assistance that you think is encompassed in assisted PD, or at least was discussed.
Well, the big break point, and Thierry and Janet can probably join me on this discussion, is around whether they assist with the treatments themselves. So some models provide assistance with actual connections to the cycler, sometimes disconnections, or manual CAPD exchanges. And so I think that's what we kind of all think of as assistance, but that model is actually probably in the minority. There's a lot of, in terms of published models. The other model is where people are coming to the home, helping with the setup of the machine, maybe helping with, ordering supplies and things, but they're not doing the actual connections to the cycler, or they're not doing CAPD exchanges. So that is a big break point between the assisted models. And actually the majority do not provide direct care to the patient as far as we could tell from our review.
You're talking about the connection itself.
Yeah, so a critical question for assisted models is this model providing connections, or is this model doing CAPD exchanges? And I'd be very interested to hear Thierry and Janet's view of this. That's what we think of as this, that's one form of assistance, but there's a lot of other models where they're bringing nurses to the home, but there's doing just the machine setup, or they're checking, the patient and doing assessments. And because if you're doing the connections, then you have to be there daily. And of the other models, you don't necessarily have to be there daily. It's also not as critical. So it's kind of it's a less sort of mission critical, if you like, model, because you could miss a visit here or there. And that's why it's such an important distinguishing feature of the models.
Terry, do you want to comment on that?
I really believe that the main difference between models is whether the catheter connection or disconnection is provided, because that's the most difficult task for the patient to do the catheter connection and disconnection, and because problems that occur during catheter connection and disconnection can increase the risk of peritonitis, and so that will have an effect on the patient outcome. So I really believe that that's really the key point of an assisted PD program, and that could make difference between the different models.
It's interesting. So the connection and the disconnection, and maybe Janet, maybe you can describe from your perspective at your program, and we're all, Janet, myself, and Matt are all from the lovely province of Ontario with a long history of assisted PD. Maybe you could describe what happens in Ottawa.
Thanks, Jeff. It's a great conversation because there are just so many different models. In Ottawa, our ultimate goal was to support patients to independence. So when we designed our model, that was really what we were thinking about, still enabling patients to stay home and provide full assistance as well as an option. It's a comprehensive approach, so provided by nurses with a case management model. So nurses do everything from full assessment, monitoring of supplies in the home, ensuring that those other things that Terry described and Matt are provided for, which again, can be very limiting factors to patients' independence. So although the connection is ultimately the most important piece and where the highest risk is, some patients just can't manage the other pieces that are involved, right? Whether it's a setup of a cycler, or it's managing their supplies, or lifting their bags, or doing all those other things. It's important to have a model that allows for all of those different elements to be addressed and supported.
And maybe I'll ask you, Matt and Terry. Again, this is an estimate. If there is data, let us know. What % of patients do you think need the assistance for the lifting, all those activities, and what % would you say probably have a barrier related to the connection itself?
I would tend to believe that, let's say, half of the patients have problem with the catheter connection, and I really believe that the nurse-assisted program among the different models is the best one because of this possibility to do the catheter connection and disconnection at home, but also because donors are able to assess the patient and to treat the patient at home in case of peritonitis, for example. I really believe that's a critical issue.
You're saying you get an extra set of medical eyes on the patient to be able to surveillance for challenges that may not necessarily be there with other models.
You've got a feedback from the nurses at home. So that's really important.
Does that come with a price? Do we pay a higher price? And is that price worth it if I'm going to pretend we're a high-income country X. I'm going to challenge you a little bit. High-income country X, that shall remain nameless, has no assisted PD program, and their government's trying to grow PD. So they're going to listen to the ISPD podcast on assisted PD. They're going to listen to the position statement, and they're going to craft their assisted PD program from scratch. And this is an issue I think they're battling with. What if they couldn't afford one using nurses? What if the only way to actually implement one would be with the use of other skilled healthcare professionals, but not nurses? Because I'm just going to challenge everybody, and I'm not saying there's a right and wrong here. I just want to get people's perspective.
So I would challenge what math are they using to make these kind of calculations, right? These are often very difficult conversations and different it's difficult to capture all the benefits because it includes hospital visit avoidance, shortening of admissions. I mean, Matt talks about a piece around peritonitis risk, and it's been very hard to demonstrate that there is a difference, but I think there could be a comprehensive look at what outcomes are, but also maintaining people on PD longer, supporting them through virtual visits, which is another thing that might be underestimated. And no one ever discusses, the cost of things like travel. And the other additional supports that are required, that getting that comprehensive support in the home can help mitigate.
Matt, do you want to comment on this issue?
Yes, I just want to be clear that although we're sort of talking a lot about the connection model or the exchange model, that isn't the only model that was included in the position statement. So other regions of the world don't have that model. And also there are some licensing issues in certain regions that certain healthcare professionals cannot do the connections because they would have to have a certain skill set. So we do want to make that distinction. I just want to be clear for like the listeners that there is a big, in terms of evaluating an assisted program, that part of connections is very important to distinguish them in terms of both cost, but likely in terms of impact of outcomes and things like that. So I think we should distinguish those two things. The costing, I echo Janet's comments that for some reason there seems to be this sort of need to restrict nurses from delivering assisted PD, but we're not putting that same restriction on in-center hemo. And we're also not properly, no one's asking, why do we need nurses to deliver us in-center hemo? So and also we're not taking into account capital costs, travel costs, all these other things. And most careful models that have looked at costing have shown that assisted PD is more cost effective than both in-center hemo and PD in the long-term care facility. And I know that in France, Thierry, the government, did a very extensive report on this that looked at the costs very carefully.
And so I guess my question is, could there be conceivably a role for a hybrid model of a customization of patient needs? To me, I think a nursing visit is critical to get additional information. We all advocate for home visits in our program, whether we have assisted PD or not, to be able to observe and assess issues and hopefully solve problems before they become of a larger magnitude. I'm just conceiving in my mind a hybrid model where perhaps the nursing visits could be less frequent, but still happen on a recurring basis to the patients, and other healthcare professionals could chime in and with the assistance. And for the patients that definitely need the connection or disconnection, we could distinguish that group of patients from the patients that may need support in other ways. Thoughts on a hybrid model moving forward?
I agree, Jeff. I think that that's, very important to have some flexibility and nimbleness. One of the things that always needs to be taken into consideration is the availability of the workers, right? Of who is actually available to do it. What are the barriers for them, to provide that level of support? There's big geographical differences in areas, and in some areas there's just very tight limitations on available people to provide the support. But thinking outside the box, looking at different options is really important. But I think when you do that, you need to consider the training and the monitoring from a quality perspective, because I think that's one of the things that sometimes gets forgotten, and that puts patients at increased risk.
Yeah, that's a really important point. It's only as good as the skill set that we're able to maintain and the competencies that we can maintain among those that are helping our patients.
What you just said about maintaining the competency and the ability to do it, what about the local community? You have 2 patients and a community is 500 people. Trying to maintain that kind of level of competence going forward continuously is super difficult, and therefore it limits how much you can apply. What about interacting with local health professionals who are in a community to provide this, and whether you have had any experience in dealing with something like home care?
I would just say that's a model that's being explored in Ontario for that reason in remote communities. And that's where the element of paid family assistance or paid friends and family assistance could be a nice model for that remote area. So I think that is being explored in Ontario, but has not been implemented yet. I'm not sure if it exists in France or other places.
It's also a very reliable, or it can be a more reliable form of support, because you've got that commitment within the community or within the family to provide that support, which brings a different element into it.
If I can say something, I just want to add the fact that the training of the helper is really the key point and should be done by the nurses from the PD centers or for a private company that could provide training. But that's really the key point. The helper should be well trained and should be able to communicate with the PD center in case of any problems.
Thierry, I might be completely making this up, but correct me if I'm completely wrong, but in Europe and maybe in France, there is a culture for the elderly sometimes to move in with a family or be cared for by a family. Is that something that I've just made up or actually exists out there?
Yes, that's correct.
Yeah, so this could be a nice model for, when we talk about assistance by family or friends, because I do know that I did have a friend actually whose mother was elderly and moved in with a family in France, actually, who looked after her for many years. I could see that model working really well in that kind of an environment.
Yes, but that's something that we must take into account is the caregivers burnout.
For sure, yeah.
Because the involvement is probably decreasing with the time spent on PD. So at a particular time, the caregiver assistance could negatively affect the outcome. I mean, we should be able to provide temporary assistance in this case and to assess regular caregiver well-being.
Yeah, I think that's a really important point about caregiver burnout. And that brings me to a point about when we use assisted PD. So maybe I'll ask Matt about this. We talked about who's doing the assistance. We talked a lot about what the assistance is. We spent a lot of time talking about connections versus not. I want to talk about when we're doing the assistance. And I know that there's different models of time limited, when patients start, when patients have a period of frailty, or throughout the course of PD care. Do you want to talk about that, Matt? And maybe also talk about being able to intervene to address caregiver burden when it's a family member that's doing it, and they may not necessarily have had formal assisted PD, but could have it in the future, and the role that it plays in that scenario.
Yeah, there's a model of starting the patient on assisted PD and then withdrawing it once it's been determined the patient and the family are confident in doing well. That would be sort of a form of graduation or self-limited. There's also a form where you're bringing it in if a patient or family member has some kind of intermittent illness or issue. Could also be used for things like peritonitis, for administering antibiotics in the home. And then there is a model where the patients are requiring chronic long-term assistance. All those patterns, although graduation has been described and short-term PD funding has been described, the ons and the offs and exactly how those periods work has not been well analyzed. We're trying to do some of that work now in Ontario to give a much richer sense of the patterns of assistance. But those are some of the models that are out there.
But some models, if I'm not mistaken, and again, correct me, are only offering it at the beginning with a time limited. In other words, it's sort of a launching off. Does such a model exist?
There are models like that, but they're not models that are doing connections.
Right.
I mean, obviously, if a person is incapable of doing connections, then you couldn't do a self-limiting model. Though to Janet's point, I mean, when there's a real goal to graduate the patient, which I think is what Ottawa is sort of goal is to graduate, then I think you're trying to facilitate as much as possible. But some assisted models are supporting people who will never be capable of doing connections, never be capable of setting up their machine. So that is not a graduation model.
Right. And Janet, COVID played a very interesting change in the model of care in PD. Do you want to highlight some of your observations about how COVID impacted assisted PD?
So absolutely. So we had a pretty robust program during COVID in Ottawa, and we certainly did see family members coming forward offering additional support. I mean, the whole landscape of what people were, not being able to leave the home and other things certainly changed things, but really did come forward to try and support family members, and in some cases hoping to limit the number of people coming into the home and exposure to family members from care providers, et cetera. But it certainly was a unique environment and interesting to observe at the time. Advantages to providing that early support with an assisted PD program, it expedites discharge. So, instead of patients having to wait for a training opportunity in a program or to get their training, you can have Home Assist provide that, and in some cases actually do on-site training within the patient's own home, avoiding travel back to PD centers, et cetera. So it can be an excellent model for a very a patient family-centered approach to care.
And I'm going to ask you each the same question. I'm going to ask you something that, again, a little bit controversial. We're going back to the healthcare makers of high income country X that are listening to the podcast and are thinking about starting an assisted PD program. Anybody who wants it gets it, or do we restrict it? Do we do eligibility? Do we do a formal assessment and say you must meet criteria A, B, C, D, E to be offered assisted PD? Right now we're lucky in Ontario, we have it funded, and nobody tells me who I can and can't put on assisted PD. And if the patient needs it or wants it because they perceive a benefit, or the healthcare team, pretty much we can offer it. But maybe I'll start with Matt, then Janet, then Terry. Should we, again, with limited healthcare resources, should this be something that we should be applying eligibility criteria, formal assessments, restricting, or anybody who wants it should get it?
Thanks, Jeff. I mean, part of our early work, we carefully tracked barriers to self-care. So these would be cognitive or physical barriers, which made PD more difficult, but may be overcome with support, and they're very prevalent. So, probably 50% of people have at least one. And so, but I do support programs tracking these things and justifying the assisted PD. One issue, though, is that, it's a challenge. Are you taking the opinion of the training nurse, the training doctor? Are you doing a formal geriatric assessment? There's work to be done there, but I think that's a good practice. And secondly, the thing that has not been done to my knowledge, which I think would be very useful, is then revisiting patients, say 6 months in, and asking what are you doing? What are the assistants helping with? And how much impact is this having on you? Because one of the very important questions is who would not be doing PD if assistance was not available? That's like a very important question. Not just they're receiving assistance, but they wouldn't do PD if assistance was not available, because that's kind of the incremental benefit of assisted PD. And that's really an unknown to my knowledge, something we'd like to explore in the future.
Janet, everybody, or we restrict it to those who need it?
So, I'm obviously a big supporter of open access, but I do agree with Matt. I think it needs to be monitored. I think that there are some structural barriers in some cases where it's not necessarily appropriate to even, provide assisted PD. Those are, in most cases quite limited. But I think it should be monitored, and I think, regardless of who the care provider is, I think there needs to be ongoing connection and assessment by nurses to be able to ensure that we're still doing the right thing for patients. That, just as Matt described, what are we doing? What assistance are we providing? Is there ways to actually move that patient to independence? But making it time limited, I have a concern with. I think there needs to be that flexibility within the model to make it much more, again, patient-centered and more individualized to the patient's needs.
Yeah, I'm going to ask Terry the same question, and maybe my own experience is that sometimes I have to be honest, sometimes it's the emotional and anxiety component of doing independent dialysis when people can do it. It's just they need that support at home to be able to overcome that anxiety and fear of doing independent dialysis. And my fear, if we restricted it, I'm providing my opinion. My fear, if we restricted it, is that we would, there's so many people that I've seen that that's the reason why, and that was the important feature why they considered peritoneal dialysis. And then they go home, and then at the 3-month mark, it's not so scary. And then they've watched the home care nurse enough times that they're starting to do it themselves. And guess what? They have a dinner party to go to, and they don't want to be at home at 7:35 to let somebody in to set up the cycler. And they want to go out and go out and have dinner. And then they realize that they can do that and have the confidence to do that. And that wouldn't have happened, I think, if we were very restrictive to only the people that we felt, and I'm putting that in quotation marks, needed assistance. Thierry, what's your perspective on this?
I have to say that I fully agree, but I just want to be a little bit provocative. I'm not really convinced that the cost of assisted PD is higher than the cost of in-center HD. So that means that if you really apply restriction, you're gonna select patients for dialysis, not for assistance, PD, assisted PD, or in-center. Do you got my point?
Yeah, for sure.
I'd just like to make one point that you raised there, Jeff, is that having assisted PD in your environment is a strong incentive. And it's an incentive for the teams to make patients eligible for PD, offer to people who they may see as marginal. It's incentives for patients and family to choose PD. And those effects are independent of the delivery of PD. It's almost like intention to treat versus as treated. And so that benefit is hard to measure. So as you mentioned, someone may have not chosen PD if assistance wasn't available. They go home, they get assistance for a week, they realize I can do this, and they stay on self-care PD. And that's a huge benefit of assisted PD, even though it was only delivered for 7 days. So it's like an incentive program.
For the unnamed country X, high-income country, is there a model where you would incorporate incremental peritoneal dialysis prescriptions into assisted PD to make it kind of work better and provide possibly less caregiver burnout or less more patients being treated by a single nurse or a single healthcare professional? And then what about adequacy? Should I even say that word if we're using it in this context?
It depends on your version of incremental PD. Just thinking off the top of my head, if you were allowing people to not have PD for 1 day a week, which was sometimes is a way of incremental that we practice, that would help in terms of the scheduling. I mean, if you're doing more like a small number of exchanges per night, say 3 exchanges per night with less than 5 liters, that's another form of incremental. Some would say, that I don't think that makes much difference. So it sort of depends, I guess, if you're doing CAPD and you're only doing a couple of exchanges a day or an icodextrin, I think it depends sort of really on what your prescription you're writing for incremental, because it's quite variable.
Well, I think that sometimes assisted PD is used to treat elderly patients who are very comorbid. So sometimes assistance is to provide palliative dialysis, like PD, particularly in patients where the KT over V or this kind of things has no sense. The main objective is to prevent symptoms that could affect the patient quality of life, like pulmonary edema or whatever. Assisted PD could be a part of the palliative care, I believe.
That's a really good point, and that's really important for us to think about as well. I want to turn to something implicit in my country that I've made up that we're going to hopefully get interest in starting an assisted PD program. I kept saying high income with the assumption that this could be only a model among high income countries, which was probably an erroneous one. Matt, maybe I can ask you, are there experiences in low and middle income countries for assisted PD? Or you think there's any specific considerations for our listeners from those parts of the world in terms of delivery of assisted PD from what the position statement was able to glean?
We did intentionally include people on the position statement from some lower income countries. My general feeling, and Thierry can jump in here along with Janet, around there seemed to be more of a use of family members, lower skilled assistants, and getting funding for those assistants, I think is more challenging for sure. And there was recommendations to include family assistants as part of PD, assisted PD from some of the lower income countries, but we did want to sort of still make it paid for by government. So that may be a model that works a little bit better in low income countries.
I think that in low income countries, sometimes they use domestic or workers that are trained, I don't know, maybe by the PD nurses to provide assistance. So that could be a possibility, I believe.
Yeah, and I think that's something that I think will be interesting to see how it evolves. A lot of countries are turning to PD, of course, because of the benefits, and it certainly is something that I think, as part of countries that are looking to grow PD or develop PD, we should be thinking about how to support assistance in those environments.
And Jeff, I think that goes back to the importance of, standardized, education and monitoring for quality as well. So, I think, even with limited access to resources, there can still be some standardization and some oversight to provide support.
I was just going to say, even like in high income countries, there are patients and families that pay personal support workers or other workers to help them, with their daily tasks. And those people are helping with PD. We just weren't sure how the model would work when they're being paid by family or patients. I mean, perhaps there could be a model where there'd be some kind of tax credit, or the government could help pay for that as long as the person was being paid specifically for PD. That might be a model that could be developed, but we're looking for ways for governments and other payers to incent assisted PD, as opposed to just having families and patients pay for the assistance.
Yeah, no, that's a really important point. I'm going to go back to this whole issue about the crux of the connection and the disconnection. Do we have work to do technologically to implement ways in which to do this in a more aseptic manner to a wider range of patients who may have physical or cognitive challenges? Do you think that we may have a technological gap that we could fill with technology that assists in the exchanges and the use of technology to allow that? Just wanted to get people's thoughts.
I tend to say yes, but at the same time, sometimes these technology are more complicated than just doing the connection, So I know that in France, long time ago, there was a device which was called UV flash. I don't know if you remember this device. It was quite easy to use, used by the assisted PD patient to save time at home instead of waiting. But we did not perform any study about this device. So I tend to say yes, that would be helpful, but it has to be very simple to manipulate.
I totally agree. I've been around an awfully long time and remember these things. So keeping it simple, sometimes adding additional technology just can overwhelm as well. So again, in thinking about it, it has to be super simple to avoid extra complication and risk.
Just a question about PD modality. Should we be offering APD and CAPD? Are there models that only offer for APD? Because the assumption in that is that it's one connection and disconnection versus CAPD, maybe multiple exchanges. What are people's thoughts about assisted PD and offering different PD modalities? Maybe we'll start with Matt and Janet and then Thierry.
I would point out that even in a 2-visit model, sometimes one visit is for this machine setup. And so that can be done throughout the day, which allows flexibility of scheduling. And then the second visit is for the connection, but they're not actually doing the disconnection, because often people who need help with machine setup or connections can actually disconnect themselves, or a family member can. So although the 2-visit, you kind of think, oh, it's a connection, disconnection, it often can be a machine setup and a connection. CAPD is more challenging because, it depends. There are CAPD models where, for example, the assistants in Ontario will provide 2 help for 2 exchanges a day, but then someone else has to step up and do the other exchanges. And I do know in France that they do support CAPD, but it requires obviously multiple visits a day. So maybe, I don't know if Terry could make a comment of how many actual CAPD patients are being supported with their assisted model.
You know, I have a concern regarding the machine at home for the older population. Sometimes cognitive dysfunction that increase during the night. So the machine at home can increase the patient anxiety or could cause problems. So if we really want to help the patient, I think that we should provide both CAPD and APD. It depends on the patient characteristics.
Janet, what are your thoughts about providing both modalities?
You know, I think it's so resource intensive is the biggest challenge with the 4 exchanges, or in some cases 5.
Yeah.
That is the limiting factor in being able to provide that. You know, it would be nice to be able to offer it. I totally agree with Terry, but I think it does make it logistically extremely difficult and significantly adds to the cost.
However, it does triangulate back to Nikhil's point about, you know, we could support incremental CAPD, and in a 2 exchange or a model, particularly for elderly patients, it may be something that's feasible to certainly provide. And many of our patients are on 2 exchanges for quite some time, who are elderly starting dialysis and do get a benefit out of it and seem to be thriving. And I know Dr. Brown at Wiener Brown has published as well on a supportive 2 exchange model. So I think that could be something to consider as part of offering 2 modality assisted PD solution.
Each of your programs is quite established in assisted PD. My program is trying to get on board with assist PD. We had a huge discussion a few years ago where it did not make fiscal sense, but we are trying to provide it. How does a program which intends to start assist PD start? What are the things that you need to look at first? And then how do you go on? Because going straight to the government for funding is not going to work. So how do you guys start? Just some advice for people who want to start.
I mean, I can give you our experience that happened in North York or Toronto, which I think led to the expansion in Ontario. You know, we first got a grant to do it, and part of that grant allowed us to do a nice comparison to show the effects of assisted PD by having 1 control region and 1 assisted region. And the fact that we had a peer-reviewed grant, I don't know if this will carry weight in Edmonton, but sort of a lot of people got behind it then because it was kind of an approved program, and that allowed us to access the home care nursing visits. We put a cap on it, so we said we'd only support X number of patients in the region, so that kind of sort of relieved some anxiety that this would get out of control, and we were able to demonstrate its sort of effectiveness and go from there, and then that allowed it to expand. So you could start with something small and just to sort of demonstrate effectiveness and get the shareholders involved, not the shareholders, the stakeholders involved early so they can see the results of the program. That's kind of what our approach was. I would say one thing though is that I wouldn't so worry much. I tell this to everyone we meet about is don't worry so much about the cost right off the bat. Make sure you get the program working well. That's with hopefully with nurses. So you're delivering very high quality assisted PD, and then you can look at ways to try to reduce the cost over time. But I would not recommend going in with a very low cost model right off the bat. I would focus more on safety and implementation and that type of thing.
But it's interesting, even in Ontario right now, if my understanding is there's variability, some of us use established home care agencies where we expand their purview of what they do within the home to include peritoneal dialysis assistance. Some of us have actually hired and under the purview of the program have nurses that support. Janet, correct me if I'm wrong, in Ottawa right now, your model is what in terms of who are the nurses employed by to perform the assistance?
So ours are employed by the hospital's nurses.
Right. And so it's even within, as other jurisdictions look to, even within Ontario, I think they've given us that flexibility to design programs accordingly. What's your experience with the assisted nurses falling under the purview of your program? Has that worked out? Have there been any challenges?
So it's worked out very well. I mean, we went to that model because of lot of the limiting factors that we encountered related to using a third party. So the challenges with maintaining competency, with availability. Um, so, we rebuilt our home dialysis program from the ground up to incorporate the community as within that model. So, it is a model that involves nurses working in, clinic, training patients, as well as supporting them in the community to provide that continuity of care. I mean, there are always HHR challenges in any model, but
What's
certainly
HHR?
Health Human Resource challenges.
Okay.
But I must say that that this model has been very successful, sustained the pandemic quite well with incredible support. In areas where we thought there would be significant challenge during sig severe weather and power failures and other things. Certainly the model did sustain itself. But I would just make a comment about a program trying to get started. You need to look very deeply at what your issues are, what your challenges are, and if capacity within in-center hemodialysis is one significant challenge that you can leverage that lack of infrastructural support to support this type of program to support people in their home. And then, of course, I mean, this is a very patient-centered approach. And certainly I would leverage all of those things.
And Thierry, tell us about the model in France. Is it nurses who are home care nurses that do other things in addition to assisted PD, or specifically nurses that are provided by the program? And again, to Nikhil's question, what advice would you give to a program trying to start assisted PD?
Okay. So in France, that's very particular because we have private nurses working in the private sector. So these nurses are looking for work, obviously, and they are paid for assisted PD, but also for other things like visiting the patient to give insulin or whatever. So that's very particular. If I have to give an advice, I think that the most critical point is to find a group of technicians or nurses who agree to be trained. And I was saying a group because if you train only one person, you will have to face with the missing visits. So you have to find a group of persons who could be trained to help the patient, and not only one person, but a group of persons.
That makes a lot of sense because you certainly need to create redundancy. If one person's sick or off or unable to do it, the whole program could be in crisis mode. So that's a really good piece of advice. I want to take the opportunity to thank all of you today for joining. I learned so much about assisted PD. There's more to learn. And please have a look at the position statement, which will be available free access at Peritoneal Dialysis International and on the ISPD website. I'm hoping that Matt and Thierry will follow up with a webinar, which we'll be giving you information about shortly, that will be taking place on the assisted PD position statement. And look forward to ongoing social media discussion about the assisted PD guidelines. Please follow us at ISPD and at PDI Journal, where there'll be ongoing tweets and discussion about assisted PD. And we'd love to hear your questions and comments about assisted PD through our social media channels. Thank you guys so much. We've learned a lot, and I hope that Country X has been listening, and I hope that Country X reaches out to all of you experts in assisted PD to help craft and design and implement their assisted PD program. Thanks so much, and hope you all have a great day.